All right, welcome back. I'm very excited to introduce our next speaker. This is Dr. Harriet Koorts, Senior Research Fellow in Implementation Science at the Institute for Physical Activity and Nutrition at Deakin University in Melbourne, Australia. She leads the Institute's Implementation Science cross-domain theme, and her research focuses on the scaling up of population health interventions. And she's here today to talk to us about a systems approach to scaling up for population health improvement. Thank you.
Okay, thank you. And thank you for that introduction and inviting me to speak today. Yeah, I'm going to talk about a systems approach to scale up, but this talk's really going to fall into two sections. So I want to introduce the concept of taking a systems thinking lens on scaling up, which is different to the current traditional models, but also show a way of using systems analysis to actually study scale up and how we actually can learn quite a lot that's very different to the traditional approaches. To preface this by saying I'm not a systems scientist, so I study scale up and I've just been using systems methods in the last sort of few years. So yeah, I'm absolutely not the expert on this methodology. Now, just to ensure that we're all on the same page with this, when I'm talking about scale up, I'm talking about replicating and extending the reach of an intervention into other localities and cities or regions. But critically, when I say successful scale up, this is when an intervention becomes embedded in a system, so it has sustainable health benefits. Now, these definitions were taken from a Lancet paper led by Rodrigo Reyes and colleagues. And what really underpins all of my research is that they looked at globally how many physical activity interventions are successfully embedded, and there's a minority. And we see this across health. We've done well in certain sectors like immunization and screening and vaccinations and so on, but in particular for physical activity, very, very few actually become embedded in systems. So typically we tend to think of scaling up as you have an intervention, you test it in an efficacy trial, you maybe test it on a small scale in a real world setting, and then you're thinking about, can this be scaled up? Our partners are engaged, can we roll this out further? However, what we actually know in the reality is that scale-up pathways are highly varied. Now, this study at the top by Devon Indix from the University of Sydney, they looked at 40 public health interventions, and only the very top row that followed a comprehensive scale-up strategy. So that's following all of those steps that I described, from development, efficacy, real-world trial, and then dissemination. But nearly half of them didn't actually adhere to this. So what it's just showing is we tend to think that scaling up, and we promote that it's something that's linear and replicative, but the reality is that isn't how it happens in public health in general. We also know they're non-linear, so spatial dimensions of scaling up, such as program reach, that's the major focus, and it's dominated our literature. But temporal dimensions of scaling up, like dynamic changes, just doesn't get much focus. Another study that looked at how scaling up and spreading of interventions exist in health services was by Trish Greenhalgh and Chrysanthi Papuzzi in the UK. They looked at interventions in health services, how had they been widely implemented and scaled up, and they identified three main paradigms. So social science, implementation science, and complexity science. Now, implementation science, what they were sort of saying is that this is a very sequential mechanistic spread of interventions. That's typically what this paradigm promotes. Social science, however, looks more about the mechanisms underpinning scale up, what works for whom under what circumstances, whereas complexity science embraces the impact of complex systems. However, implementation science has been the dominant approach. And the reason at the start where I had the two definitions of scale up sitting under an implementation science umbrella is because scaling up is typically embedded in implementation science. That's implementation science, scientists study it and so on. But I'm just going to explain to you as I go through why this has possibly led to us approaching scale up in a very linear way. The other point I want to make is about how the term systems is actually conceptualized in scale up. So these images are of three scale up frameworks in nutrition, physical activity, and global health. All of them refer to the term system. However, it's typically either as a context, so in the health system, or at a level. So they talk about the country level system. And that's actually very different than when you talk about systems from a complex systems perspective, which is more about feedback, adaptation, and emergence. So it's not that that conceptualization of systems is incorrect, it's just it's being used in a different way. Now, this quote here in particular resonated with me. This is from a Lancet paper by Harriet and colleagues, and they wrote an article saying that in public health, we need a complex systems perspective because the problems we're studying are complex and they exist in complex systems. And they said that changing the mechanisms and infrastructure that underpin public health evidence and action is itself a complex system challenge. And I actually feel that that's exactly the same as scaling up. So when we scale up, we focus on the intervention, we focus on the behavior we're trying to change in the setting, but we don't treat the process of scaling as complex in itself. So I'm just going to talk to you about a systems thinking approach to scale up. So Harry and I put forward this concept that what about if we considered scaling up where we focus on generating changes within the system itself? So we shift our attention away from the intervention, but actually to achieving an system outcome at a systems level, because that then really adheres to that definition of successful scale up. And really, you know, scaling up is an event within a system as well. So we really shouldn't treat the two as independent. So this on the left is just an example. This is the image of what sort of we would probably conceptualize scaling up as, that sort of widening the reach and implementation of an intervention. Whereas what we're describing is that if we begin by considering the system first, that then can indicate what types of intervention are going to be appropriate to implement. So things like the system's readiness, its capacity for implementation, historical antecedents of the system, what previous things have happened in that system and what's the likelihood for change. And this isn't about putting a systems approach against a sort of traditional approach. These exist on a spectrum and both can exist in continuum at the same time. And irrespective of which approach you take, they actually both require changes in the system for sustainability anyway. And the end goal remains the same, that the intervention becomes embedded in a system. So, the endpoint's identical. It's just thinking of a different approach because we potentially have a greater chance of getting sustainable health outcomes if we're changing our systems, not trying to force interventions into existing systems. So I'm just going to change gear kind of completely and illustrate a way of using a systems analysis method to actually study scale up, and how by doing that, it sort of reiterates, I think, some of the points I've made about the value of taking a systems approach to thinking about scale up. So in 2018, we actually did a study where we wanted to understand why certain interventions get scaled. So this study was based in Australia. I'm sure the parallels are probably quite similar here in the US, in that we have a lot of interventions that have been rolled out by government at a national level, and they really have varying levels of evidence underpinning them, and really great interventions that are highly efficacious just never get adopted by governments. You just cannot get buy-in. And so we wanted to study, okay, so of those interventions that are being implemented across the whole country, why, how did they get there? And are there certain mechanisms that underpin them? Are there any leverage points that we could target in other settings to help improve other interventions? And do our scale-up frameworks, are they really applicable to this process? Like, are they relevant to what goes on in the real world? So we use the WHO ExpandNet framework, and look, there are quite a few scale-up frameworks in the field. My personal view is this is the most comprehensive one. It's the most thorough, but the framework essentially has 5 core domains that it says that are critical for scaling up. And in those domains, there are certain attributes that you need to consider that all have factors influencing them as to whether an intervention will go to a population level. So in this particular study, we identified 7 interventions in Australia that met our criteria and had gone to scale. And these were a combination of physical activity and nutrition interventions. Now they were across the lifespan. They'd been implemented in every state in Australia, and they were in multiple different settings. So they were highly diverse. There were 26 different partners that were relevant to those interventions. So these were individuals from universities, non-government and government organisations that had some involvement in getting those interventions scaled up. I'm not going to talk about the methods in depth for the purposes of time, but I'm happy to take any questions. But we used a realist approach to understand this process. So we conducted realist interviews, and that's a realist is really about trying to understand what works for whom under what context. So we interviewed our participants, and the purpose was to test the WHO framework. So we would say to them, the WHO framework says an intervention needs ABC. Do you think, is that the case? Did you experience that? So we were constantly testing it. And that led us to develop these context mechanism outcome configurations. And this is what we then depict in a map, which I'll get to in a second. So this whole interview and analysis process led us to identify 63 different pathways that led to successful scale up. So there were 63 different combinations of events that occurred that then meant that that intervention was rolled out. Now, what I'm just showing you now, this is actually our brief model of scaling up. So this is a systems map that essentially depicts the WHO framework and how all those domains are interrelated. So in the very center, those blue bubbles, there are 8 of them. These are the core outcomes that were essential for a successful scale up. So it could be replicated, there was implementation capacity at the organizational level, community sustainability, stakeholder buy-in, there was evidence for impact on the target outcome, community could adopt it, political support, and system level embeddedness. All of these bubbles that are highlighted in green, they relate to the WHO framework domains. So already, if you look no further than this, you can just see how these domains we have in our frameworks, be it an implementation framework or a scale-up framework, they're highly interrelated. Yet it's very difficult to depict that in a document that outlines in chapters different domains, but they're very, very related. Throughout the maps I'll show you, where there's a solid black line, that indicates there was a positive relationship, and a dotted line indicates there was a negative relationship. So this is one of those overwhelming systems maps, and I don't expect anyone to be able to read the bubbles. I'm going to break it down and talk through it, but this is an exploded version of the previous map. So each one of those coloured areas represents one of the WHO domains. And in the centre, you can see we still have those 8 core outcomes, okay? So if anybody has failed or trying to scale an intervention and finding it very, very difficult, this is a good illustration of why it's so challenging, because it's highly complex in terms of the interactions between different contexts, outcomes, and the mechanisms that underpin them. Now, you can't really see on this particular image, I will move through the slides, but if there's a bubble that has a black ring around it, that means it's a context. All the bubbles in blue in the center are outcomes, so everything else is a mechanism. So there's an enormous number of mechanisms, and these are potentially leverage points, okay? So I'm just going to talk through some of the main sort of top outcomes we found from this. So community sustainability and stakeholder buy-in, these were the most highly connected in the map. So they were sort of, you could argue, you need to look at this more, but you know, if you're going to influence 2 of the outcomes, they're the ones that were most highly connected, so potentially leverage points. Likewise, the domains of the scaling up strategy and the actual intervention, they had much greater focus amongst participants. So we had more than 3 times the number of mechanisms were related to the intervention, and more than double the number of pathways. Now, we don't know if it means that, you know, this is the participants' mental model of scale up. This is their perceptions of it. So is it that we just think more about things we can control, which is the strategy and the intervention, or is it that they do have a higher role in scale up? We don't know. The other interesting finding was that it's a variable and dynamic relationship. So the bubble in red is a context, and the bubble in blue is an outcome. Now, in the literature, we tend to have a context outcome depiction. So if you have an ideal context, you're more likely to get your intervention scaled up. Like, it's got high reach, it's more likely to be scaled. But as you can see in this pathway, along the whole continuum, both negative and positive influences happened. So it basically said that you could have an ideal context, but it doesn't necessarily lead to a positive outcome. So you can sort of reject that sort of causal depiction we tend to have in the field. The other interesting finding was that interventions were scaled based on multiple sources of evidence. So the bubbles in red, you won't be able to see them, but they basically capture that we had interventions that had indirect evidence, so evidence from another country, but sort of pretty similar, so good enough to go. Some evidence was from pilot studies, some was actually no evidence at all, but it was based on feel-good factors. So they would say, we didn't actually have any evidence it changed nutrition behaviors, but the people really liked doing it. It was just, it was a really great environment. So that's a really big spread of types of evidence, but all very valuable evidence, because this is policymakers, you've got to understand. So for them, they have a much broader range of evidence uses than what we maybe do. But interestingly, all of them had a positive relationship with perceived legitimacy and credibility of the intervention. So it didn't matter really what the evidence source was, as long as it was perceived to be credible, that was sufficient. Now, what you can see on the right is an exploded version of what's on the left. It's the same blue bubble. And we have the same thing. So that blue bubble, which is perceived credibility and legitimacy, was linked to 4 of the main 8 outcomes. And it was all positive. So if you think, we as scientists strive for like high and credible evidence, but really as long as it's perceived credible, that's more likely to get something scaled up than actual evidence. The last finding that was quite interesting was that evidence for impact on the target outcome was actually much less important in the reasons why interventions were scaled than other factors. So one of the WHO domains is around monitoring and evaluation. And obviously, like, our academic participants talk to that heavily, but only 3 pathways actually related to evidence for impact as being a key part of the scaling up process. Yet we had 63 pathways in our map, and 3 of them related to evidence, and only 1 of them related to evaluation. So one of the things we found was that not all of the interventions had an embedded monitoring and evaluation process. They all had some form of evaluation, but the minute funding changed, evaluation was what would be cut. So again, you can take this 2 ways. You can sort of interpret it to say, oh, well, decision makers are scaling interventions and they're not thinking of the evidence, so they're not evaluating things. But you could also look at it to say that the value that's placed on and things that are important to decision makers when deciding what to implement doesn't necessarily marry up with what us as academics want it to be and think it to be. So there's sort of some common ground, and there's a lot to unpack there. I don't know that it's as simple as saying poor choices or wrong choices. It's just there are different choices being made than what we want and think should happen. So in terms of some of the implications and recommendations from this, I mean, I think that study, for us, it was a really interesting way of looking at scale up, because today, when we've learned a reasonable amount of scale up, it's a fairly understudied area of it, in the context of other implementation science fields. But really, a lot of our literature has come from retrospective case study analysis, or studies that have looked at certain events and how they led to actions. And that's been like extremely useful in terms of developing tools and frameworks to support scaling up. But this was one of the first studies that actually managed to look at the interaction between mechanisms from, and the systems that actually influence this. And I think one of the big implications is that what we currently have of context to outcome depictions of scale up, and the overemphasis we place on it on systems as just an impact, possibly oversimplifies the process. And what this study showed was the perceptions, worldviews and goals of those actually involved in scale up are highly influential. The other thing is that this has implications for how we plan, approach and evaluate scale up. I mean, the variable and dynamic relationships we saw between mechanisms and outcomes just show that how we anticipate the likelihood of system-wide institutionalization is potentially challenging, because any one context that might look like it's going to be ideal for scaling up really not necessarily be the case. We did also find that political alignment was the cornerstone, so that was absolutely critical. I've had people ask me before if there was one thing that you could change, one takeaway, and I think in essence the study showed that there literally is not one thing. It's all interrelated, but political alignment was by far, in interviews, the strongest component of what would depict whether scaling up would occur, completely unrelated to the type of intervention or how much evidence you had. Now, look, this is, complexity science and systems methods. I mean, they've informed the expansion of programs for quite some time. And, there's knowledge about system characteristics such as system capacity and innovation system fit in scaling up. Like, we know these occur, and that's not new. What is sort of different is that systems approaches are very much underutilized in scaling up. And I think I wanted to bring in, for those who were able to see Bethany Kwan's plenary yesterday, day before actually, on designing for dissemination and sustainability, all of the aspects that relate to systems that underpin the three components of designing for dissemination, they all relate to system factors that you can actually understand using systems approaches right at the very beginning of designing an intervention. So, the innovation system fit, how appropriate it is for the system it's going to influence. Is there system readiness for change? These can all be done in advance. And there was mention in the talk previously about embedded researcher practice partnerships. And again, these are sort of things that can be set up before you actually start testing an intervention to scale up. Very much like sustainability is not considered as an end last thought in the process, which is typically how we've dealt with it. So in terms of recommendations, obviously there's many different ways of thinking about anything, and we're just proposing that maybe a systems thinking approach that's different to a traditional linear implementation science paradigm could offer different opportunities to study scale up and maybe lead to different outcomes. And systems analysis methods are really useful for giving insight: who's in the system, what's their responsibility, what do they do, and what can they do. There's also potentially, we need an increased focus on the distal factors. So that's things like perceived political favorability, credibility of the evidence. We don't tend to focus on that when we're thinking about scale up. We tend to focus on those aspects that we can influence, such as the intervention attributes, its replicability. And that's not to say that we shouldn't, it's just we've had less emphasis on those other distal factors to do with, individuals' perceptions and goals and worldviews. And lastly, in the last couple of minutes, I just want to finish on a tool that can be used to actually plan implementation and scale up that we developed a few years ago now in 2018, and it does have a systems thinking sort of underpinning it, and that we tried to advocate that you should consider the systems you're going to try and scale into very much from the outset. And this tool is something that you would do it's for academics, it's for your partners, you do it together or independently, and it's not intended to solve the scaling up process or necessarily tell you whether your intervention can be scaled. It's not a prospective scalability assessment, but what it is, it's an exercise you do to characterize the scale up context. Helps you to pinpoint gaps in the planning process, discuss any target areas of importance, and it has very much an emphasis on disparities in health. So on the right, you can see the grid. That's a 15-item checklist. You don't get a score by doing it, but you essentially work through those questions, and that can help you understand where you're going to be implementing your intervention. On the left-hand side, it's the different factors that are relevant for implementation. So the intervention, implementers, delivery setting, environment, etc. And all of this is based on evidence. So it's drawn from frameworks like the CIFA and Durlac and Dupree's work. It's not a new framework or model. It's just a how-to planning tool, essentially. So we've used this in workshops with our partners, and we get roundtables and we get individuals to discuss it. And that's a way where you can start identifying in your system what are the potential challenges that may occur when you intend to implement or scale something in the future. And thank you. I'll take any questions. I can see it. Can't see the chat anymore, but I have a question.
Sorry, thank you for your talk. This is Michelle Rousey, and I'm curious. So one of the things you mentioned was, it sounds like one of the main drivers for being able to scale interventions was the political buy-in. And I think in tying this to one of the speakers yesterday, I think they also talked about how like taking advantage of politics and the political culture and where things are. Can you talk about how if there was like an example in Australia or in the literature that you found, like what I'm thinking of is, you know, National Heart Month, and maybe that was used as a platform to launch a cardiac rehab program or something like that. Were there examples like that that you saw in your research?
Yeah, and yeah, it's a good question. And there were probably two that were quite important. One particular intervention that it went national, and it was like an online television kind of campaign. They actually said they took a bipartisan approach. So they targeted both the party in power and the party that wasn't in power. And that was quite unique. There was only one that had that strategy. And that was a little bit like the talk we had yesterday about disseminating to policymakers. It's considering both parties, because one thing we find in Australia and possibly here is as soon as a government changes, they often will wipe out any initiative that's already being implemented purely just to not be doing what the previous government did. So that's a real problem. And that happened to a number of these, even though they were actually doing quite well. The other thing, we had an obesity strategy launched at one point, an obesity plan, like a national obesity plan. And that led to a few interventions suddenly being adopted. But interestingly, one of them that actually is still going and been really successful in terms of reach and uptake was completely adopted purely for that obesity strategy. But the actual purpose of the intervention is not to reduce or target obesity. It's actually about other skills related to nutrition. But it's sort of similar enough, it kind of fits the policy, you know what I mean? And so that timing was magical. And so that intervention is actually very good for what it's intending to do, but it was never intended for the policy it was aiming to meet. So that's been some of the criticism about that process. So yeah, and I often sort of wonder when we, you know, design trials, I don't know if other people experience this, I find increasingly people are wanting my input on their work as an implementation scientist, but when we scale, we don't get political scientists involved, when we probably should, really, because understanding the political context is probably more useful to getting something scaled up than anything else.
Thank you so much. This was fascinating. I feel like I maybe understand systems science a little bit better. I was really interested in what you had to say that later in the, these later stages of scale up and adoption, that, valuation becomes devalued. It's just not the priority anymore. That the outcomes are maybe at that point presumed that you wouldn't have gotten this far if it didn't work. Can you talk a little bit more about, what happens at that point? How do you make sure that you're still making the impact that you intend when it's not the priority? Yeah, and that was huge, and all of the academic participants, that was a real source of frustration, like tension. And I think one of the things that really came out, and this is not a new concept, but that having outcome measures that are of the value of the partners you're working with, that was, and particularly for a number of these interventions, because they were nutrition, the scientists really wanted like BMI-Z scores and like the kind of like hard, like quantitative, like robust measures of changes in weight. That's not of interest to the policymakers. They needed some like health outcomes in some respect, but yeah, they just didn't value it. And what ended up happening for some, and I wouldn't want to allocate to any intervention in particular, but they would just do independent evaluations that weren't no longer embedded in that trial. And that's part of the problem. Again, we often get criticised, or like programs in Australia get criticised because they don't have evidence for impact. And one of the problems is it's very difficult to capture evidence for impact at a population level and actually attach it to an intervention because there's lots happening. But secondly, when evaluations get cut, it's not through want of trying from the scientists behind the interventions. It's simply that it's no longer something they can do at the level they maybe had intended. So we have the situation where we end up reporting reach. And I don't know if it's the same here, but it's reached like 10,000 people and so everyone's happy with that. And that is really good, but we can just never quite get to the next point of evidence.
Hello, Thank you so much. I enjoyed that so much. You talked about, you had that little model with the practical reality versus, what you want to do. I was wondering how you guys base that, that would be, where did you find that, look for that?
Which model?
Oh, the one it had going up the hill, and then the little thing like that, it was talking about the practical reality versus what you want to do.
It was your little graphic with the person on the bicycle.
I didn't do that one.
That wasn't you.
That was the one before, yes.
Sorry.
No, it's okay. That's all right, as long as it was my,
I saw
I've
it.
already forgotten my slides in a minute.
Sorry. Get my foot out of my mouth now.
Hi, my name is Jen Jones, and thank you so much for your talk. It was amazing. I totally agree with you that we need to put the systems in the front so that we can really look at scaling up. And then I worked with Bethany on the monoclonal antibodies project, and we did a fantastic job with the Native American community. My fear is we're done with the campaign, but there's still COVID. What can we do at this point?
Yeah, and I think that's something I didn't say in this, but most of any steps in this process of scaling and monitoring value, it's like a continual iterative thing as well. And so the changes of COVID, have impacted enormously, and even the way decisions are made are very different to what they would have done previously. And all I can suggest, and that's very much conducive to a systems way of thinking. It's continually adapting and changing, so you almost have to be monitoring it and changing your approach and strategies as the context, whatever the context changes, like you described with COVID. But yeah, it's huge, and I don't think we're fully understanding all the pure impacts of COVID on any of our initiatives at the moment.
We have a question in the chat here. So in your research, there are many drivers here. Are there any of them that you identified that will completely stop scale up? What are these deal breakers? So for example, if you don't have X or don't have a link between A and B, then there is no way the scale up will be successful. For instance, the buy-in from those with the resources. Can you speak to deal breakers?
Yeah. With the apps, buy-in, obviously the first one is the absolute funding. The minute that goes, that's the end of it. And of the 7 that we studied, only 2 are still going, and all because of funding cuts. So the other one is absolutely political. So I think one of my first slides was that community buy-in and sustainability, that was really connected in the map, but political aspects, if you didn't have political support, you would not be going to scale, given that the reality is when we're relying on governments to deliver most of these. When we get to this level, often it needs to be a government that's actually going to do this. And so it's just a no-brainer that they have to be fully on board. We're not able to really push these out anymore at that point as academics.
A few more minutes. Any other questions? Just acknowledging that's exactly what they're saying in health systems too. It's slightly discouraging. I mean that. Can you talk a little bit about how you keep going in the face of discouragement?
Like, I know this is it is quite a depressing. And I feel like even with a lot of implementation talk, it's all things that don't go wrong. And that we've had lots of initiatives that have got up and been really successful. But I think as long as your core is still trying to do the best in health and trying to improve health outcomes, you just have to keep going. But I 100% since starting this type of work, it's made me have a greater appreciation of not just having stakeholder partners, but actually trying to find ways to be able to work in their organization, these embedded things. I really don't think we can do this by having our ideas and then we contact and bring our partners in. We need to be in their organizations, working in parallel with them. I think that's the strongest way to not be discouraged and have a bit of an influence.
Absolutely. And Dr. Bayless sent us the link to that figure from her talk. And I think it's that same idea we have this beautiful vision that we have this wonderful intervention, wonderful programs, strong evidence base. We've tested it with pretty friendly settings, and then we try to get it out there in the world, and there's all these pits and valleys along the way that we have to overcome. And maybe there's opportunities for research on how do we drag ourselves out of those pits and valleys. How do we keep going? How and maybe how do we make sure that there's enough of a cultural demand for what we're doing, that there is continued consumer demand for what we're doing.
Yeah,
And it came up yesterday too, as you mentioned, in the dissemination. to policymakers.
And I've left some resources in the handout attached to this talk that hopefully will be useful answering some of that.
All right, well, we are at time. We're going to take about a 15-minute break, and then we have our networking lunch. I believe that's what's next. Yes. And so we have two different options for you for the networking lunch. We have a wonderful panel on practical advice on getting funded in pragmatic research. If you've ever wondered, how do we actually do this? Then we have 4 very successful researchers joining us to talk about their experience. And then in our other room, we have Dr. Kathy Bodine talking about resources for academic entrepreneurs. So if you want to go learn about commercialization and use of these tools that they've developed for working with academics for commercialization purposes, then that will be in our other room. Otherwise, we'll see you in about 15 minutes back here for networking lunch. So feel free to go get your lunch.